everybody. Thanks for being a part of it. Like Steve said, my name is Chris Fine. I'm one of the third-year general cardiology fellows at the University of Louisville in Kentucky in the United States. And I'll be presenting the journal club for this week. And it really goes back to a systematic review and a meta-analysis from our inaugural JACC Cardio-Oncology issue last September. And it's focused on the breast cancer patient and the efficacy of Dexrazoxane in preventing anthracycline cardiotoxicity. So a brief overview, we'll start with a few provocative questions about the topic. We'll segue into the background of the drug itself, where the drug came from, what were the initial thoughts on the drug and its use in our cancer patient population. Now have recommendations changed along the way, kind of leading up to our current recommendations. We'll have a European perspective and an FDA perspective as far as the United States are concerned. That'll segue back into revisiting our journal topic of interest. And then we'll have a few more kind of thought-provoking questions, some geared towards our oncology colleagues, and then some geared towards the cardio-oncologists and how we could be the most helpful in the care of this particular patient population. And then we'll end with our post-test questions with answers as well. So the first question, so what is the proposed cardioprotective mechanism of Dexrazoxane in the setting of anthracycline-induced cardiotoxicity? A, the ability to act as a strong iron chelator and to displace iron from anthracyclines via its active metabolite. B, the prevention of complex formation between topoisomerase 2B and anthracyclines. C, the stabilization of cardiac myocyte cellular membranes by reducing lipid peroxidation. Or D, both answer choices A and B. Pretest question 2. What was the original patient population receiving anthracycline chemotherapy whose incidence of secondary malignancy after receiving the drug led to hesitancy in its prescription? A, the non-metastatic breast cancer patients. B, metastatic breast cancer patients. C, leukemia, lymphoma patients in childhood. And D, leukemia, lymphoma patients in adulthood. And the final pretest question, based on available meta-analysis data in the breast cancer patients treated with anthracyclines with or without trastuzumab, which patient population would potentially benefit the most from cardioprotection with Dexrazoxane? A, non-metastatic breast cancer patients with plans to receive less than 300 milligrams per meter squared doxorubicin. B, survivor of childhood leukemia with non-metastatic breast cancer patients who have already received 240 milligrams per meter squared doxorubicin with plans to receive an additional less than 300 milligrams per meter squared doxorubicin. C, non-metastatic breast cancer patients with known non-ischemic cardiomyopathy with plans to receive less than 300 milligrams per meter squared doxorubicin. And D, metastatic breast cancer patients with multiple risk factors for cardiovascular disease with a normal echocardiogram plan to receive less than 300 milligrams per meter squared doxorubicin. So segueing into the background of Dexrazoxane. So since its induction in the early 1950s, anthracyclines have widely been used for treating a variety of solid and hematologic cancers in both adults and children. And in the early 1970s, a scientist named Eugene Herman at the NIH discovered that Dexrazoxane reduced anthracycline-induced cardiotoxicity. So Dexrazoxane was approved by the U.S. Food and Drug Administration in 1995 in the form of Zinacard for the use of cardioprotective agency in patients with metastatic or advanced breast cancer who had received or reached an accumulative dose of 300 milligrams per meter squared doxorubicin and are continuing to receive doxorubicin or an associated anthracycline. Totec was also FDA approved about 8 years later, and it was Dexrazoxane with the indication to prevent local injury with extravasation of anthracycline during a chemoinfusion. So in addition, the American Society of Clinical Oncology recommends considering dexrazoxane as one of the possible strategies to avoid cardiotoxicity during the administration of high-dose anthracycline in adult cancer patients. So in the molecular structure of dexrazoxane, it's a cyclic derivative of EDTA that readily penetrates cell membranes. And the mechanism of cardioprotective activity, it's not fully understood, but in myocardium, anthracycline metabolites bind to ferric cation, releasing free radicals. And this results in alteration in permeability and the induction of apoptosis of the cell itself. Anthracyclines also inhibit cardiac topoisomerase 2B, causing double-strand DNA breaks and activating death pathways. So the proposed mechanisms of dexrazoxane cardioprotection, it includes its ability to act as a strong iron chelator and to displace iron from anthracyclines via its active metabolite, ADR 925. In addition, dexrazoxane, it prevents complex formation between topoisomerase 2B and anthracycline, further reducing cardiotoxicity. So despite clinical evidence of cardioprotection and these proposed mechanisms and the recommendations of our current cardiology societies, its use as an agent is still fairly limited in clinical practice. So these are the two formulations of dexrazoxane available in the United States currently, which we've alluded to. The first of which is Zinacard, which got FDA approval first. And as far as its package insert and its FDA indication goes, it's for cardioprotection in women receiving either fluorouracil doxorubicin or cyclophosphamide chemotherapy for breast cancer who have received an accumulative doxorubicin dose of greater than 300 milligrams per meter squared. And Totec, which came out in 2007, is a topoisomerase inhibitor used as a detoxifying agent for the treatment of extravasation resulting from IV anthracycline chemotherapy. You would give Zinacard 30 minutes before you receive your doxorubicin dose. And remember, it's only for additional doses that exceed an cumulative lifetime dose of more than 300 milligrams per meter squared. And in patients with renal disorder or creatinine clearance issues, you can still give dexrazoxane, but you would reduce the dose by half. And for Totec, for protection of extravasation injury from anthracycline, you would give it within the first 6 hours after the index extravasation, and you continue it for 2 additional days after the initial infusion. So there's a lot of text on this slide, but it really boils down to how we administer both of these drugs. So for Zinacard, for cardioprotection from cardiomyopathy, you would typically give a dose of 10 to 1. So if your dose of doxorubicin that day is 50 milligrams per meter squared, you would administer a pre-dose dexrazoxane of 500 milligrams per meter squared. It's given as an IV infusion over 15 total minutes, never as a push. And after you complete the dexrazoxane dose, you would want to give or start the doxorubicin within 30 minutes after completing the dexrazoxane. For Totec, if you notice that you have extravasation in the clinic of your anthracycline, remember you can give the dose, the first extravasation protection dose, within the first 6 hours. It's given as a gram per meter squared, and you infuse it over an hour or two. And then the following day, you'll give the same dose, and then a following day after that, you'll give half dose, and that will complete your cycle of doses for extravasation protection. The key with this is you'll want to try to give the doses as close to 24 hours apart as possible, which can be logistically challenging in an infusion clinic. And so that was the background on the drug itself. A little more background on our hesitancy with its use. So there are concerns that dexrazoxane could mitigate the anti-tumor activity of anthracycline in breast cancer patients and non-breast cancer patients, including those with AML and MDS, and also increase secondary malignancies in studies of childhood lymphoma and leukemia after dexrazoxane was used. This controversial data led to the limited use of dexrazoxane in clinical practice. However, in 2017, The European Medical Agency concluded that dexrazoxane should not be contraindicated in children or adult patients with breast cancer at the highest risk of cardiotoxicity. The EMA found no data indicating that dexrazoxane was associated with an increase in second primary malignancies, interfered with chemotherapy, or increased the risk of early death in children. With that information, the Committee for Medicinal Products for Human Use, or CHMP, therefore concluded that the product information should state that the medicine is contraindicated in patients under 18 years old who are intended to receive a total cumulative dose of less than 300 milligrams of doxorubicin per meter squared body surface, or an equivalent dose of another anthracycline medication. So those recommendations were mostly informed by, 13 total studies, but the one that carried the most weight with this was this Cochrane review, this meta-analysis. It included 11 RCTs, which addressed dexrazoxane. So the total number of patients, it was a little over 1,600, roughly split half and half between the dexrazoxane group and the control group. So a little numeric breakdown of the studies that were included in this Cochrane review. So 8 of the studies, the control group did not receive a cardioprotective intervention. That was a little over 500 patients. In 2 of the studies, the control group received placebo, which was a little under 300. 6 studies included adults, 3 included both children and adults, and 1 was solely children. 9 studies were diagnosed with a solid tumor. The majority of the patients included in these studies were adults with advanced breast cancer, which is the patient population we're the most interested in. In 1 study, the patients were diagnosed with leukemia. In 6 studies, they received doxorubicin. In 3, they got epirubicin. And then in 1, they got either epirubicin or doxorubicin. The ratio of study drug, which was dexrazoxane, to anthracycline dose, it varied in the studies. It was either 6.25 to 1, 10 to 1, which is our current dose recommendation, and then 20 to 1. In 5 of the studies, it was unclear if patients in the intervention or control groups received similar cumulative dose of anthracycline. In 3 of the studies, the patients in the intervention and control groups received comparable cumulative anthracycline doses, and in 2 of the studies, the patients in the dexrazoxane group received a higher cumulative dose of anthracycline, which was about 100 milligrams per meter squared more than the control group. In addition, none of the systematic reviews had evaluated the cardioprotective effect of dexrazoxane exclusively on breast cancer patients treated with anthracycline with or without trastuzumab, which is where our study comes in. So the aim of this study was to provide the first comprehensive systematic review and meta-analysis incorporating studies that evaluated the cardioprotective efficacy of dexrazoxane exclusively in breast cancer patients treated with anthracycline with or without trastuzumab in both early and metastatic settings. So in order to be eligible for this systematic review and meta-analysis, the authors used the ICOS criteria. So for the population, it was all stage breast cancer patients undergoing anthracycline-based chemo. The intervention was dexrazoxane. The comparative intervention was placebo or any other treatment. Outcomes were clinical heart failure or cardiac event, which we'll get into the definitions of that they used. And then the study design was ideally RCT or observational trials, which were mostly retrospective in this particular case. Exclusions were pediatric studies and studies with overlapping populations and studies with incomplete data. So there were 2 investigators that independently searched Medline, Cochrane, and Embase's databases in the usual fashion per recommended guidelines by the preferred reporting items for systemic reviews and meta-analyses and the Cochrane Handbook for systematic reviews of interventions. They looked at all studies from January 1990 to March 1st of 2019. So almost 30 years of data. So the primary outcomes were the development of symptomatic heart failure or cardiac event. So symptomatic heart failure was defined as an expression of clinical heart failure according to the study definition, which there was a lot of heterogeneity in there. And then cardiac events, that was defined as subclinical heart failure, which was defined by histological abnormal findings on endomyocardial biopsy, LV function abnormalities, which was assessed by echo or MUGA, or hospital admission due to cardiac causes. Each study's definition of clinical or subclinical cardiotoxicity, it was accepted for this systematic review, considering that it was plausible and sufficiently comparable to the pool. And definitions of cardiac function, excuse me, it ranged the gambit. So it ranged from MUGA only data, MUGA or transthoracic echo data, or only transthoracic echo with or without associated clinical definitions of heart failure. Two of the studies included in this systematic review didn't need a clinical definition of heart failure to identify patients to be included in their initial studies. And then the details are in the supplemental data from the study, but none of them used the same definition as our current accepted definitions from the United States or European guidelines for cardiotoxicity. Secondary outcomes were interference in oncologic treatment associated with Dex exposure, which was mostly in the form of oncologic response rate, overall survival, and progression-free survival. So for data extraction, they looked at patient characteristics, treatment regimens, outcome of interest, and follow-up period. They were systematically collected by the same two investigators. Divergences were resolved by consensus amongst the two of them with a third-party moderator. For quality assessment for the non-randomized trials, the good research for comparative effectiveness checklist was used, which is pretty standard. And for the randomized control trials, the Cochrane collaborative group methods were used, which is also standard. Eventual divergences were also resolved by consensus with a third-party moderator, and a rated potential risk of bias was made by applying a rating of low, high, or unclear for each study. So the results showed that a little over 2,100 female patients were identified with metastatic or advanced breast cancer. Those were from 5 studies. 5 studies totaled 1,100 patients. Non-metastatic breast cancer was 1 trial, a little over 800, and early stage breast cancer was 2 trials, about 250. All the patients received doxorubicin or epirubicin as their anthracycline-based chemo. The average cumulative dose of anthracycline ranged from 240 to 730 milligrams per meter squared, and the dose ratio of Dex to anthracycline when used was 10 to 1 or 20 to 1. Trastuzumab was part of the treatment only in 2 retrospective cohorts, but none of the randomized control trials. Non-randomized trials were judged as low risk of bias in all bias domains. 3 trials had low risk of bias in the randomization process, 1 in allocation concealment, 1 in double blinding and blinding of outcome assessor, and 6 in selective reporting. All trials had at least 1 domain at high risk of bias, and the retrospective cohort studies were considered to be of moderate quality. Dexrazoxane therapy was associated with a lower risk of heart failure compared to the control in patients receiving anthracycline-based chemo alone, and that was 1.2% versus 9.2% compared to control, with only RCTs reporting these data points. Cardiac events were also lower in patients allocated to dexrazoxane when compared to control, which was 9.4% versus 15.5%. In 2 of the 9 studies, patients had already received anthracycline-based chemo months or years previously. Among these patients who were re-exposed to anthracycline, dexrazoxane possibly reduced the risk of heart failure, but it wasn't clinically significant, and the risk of cardiac events. For cardiac events, the relative risk was 0.32 with a confidence interval of 0.19 to 0.54, which was statistically significant. The benefit of adding Dex to anthracycline treatment, it was also consistent in the subgroup of patients who were exposed to anthracycline for the first time, which is interesting compared to what our current guideline recommendations is about cumulative dose thresholds and not to be given for first-time patients. The risk of heart failure was significantly reduced in those patients as well. But you can argue that they were at lower risk to begin with. They were also the risk was also significantly reduced for cardiac events. In regards to how the Dex affects cancer treatment efficacy, so in 5 randomized trials, the partial and complete response rates were assessed at different follow-up intervals. Similar results were noted in groups exposed or not to Dex, with a p-value of 0.62 and partial response rate, a p-value of 0.1. So stable disease was reported in only 3 randomized trials, and similar results were noted between the 2 groups. Overall survival was also similar between the groups. No subgroup effects were found when stratifying the trials according to previous anthracycline exposure. Progression-free survival was similar between the groups, but in the subgroup studies included patients with more advanced disease and re-exposure to anthracycline chemotherapy. The use of dexrazoxane was associated with a decreased risk of disease progression, interestingly enough. And in the subgroup of studies without previous exposure to anthracycline, Dex was associated with no significant difference in progression-free survival. So in the systematic review and meta-analysis, including patients with both early and advanced or metastatic breast cancer exposed to anthracycline, an observed lower rate of clinical heart failure and cardiac events in patients receiving dexrazoxane compared with controls without a detrimental effect on the oncological response. An important question is whether cardioprotective drugs reduce the anti-tumor efficacy of anthracycline and thereby comprise oncology treatment and affect survival. A previous systematic review, including several types of tumors in adults and children, suggested that patients treated with Dex might have a reduced response rate. However, an updated version of the same meta-analysis, or an update on the same meta-analysis, did not confirm these findings, and these results are aligned with contemporary data, which shows that Dex does not compromise cancer treatment. Regarding breast cancer patients exposed to both anthracycline and trastuzumab, the cardioprotective effect of Dex was similar, but it's important to acknowledge that evidence comes from 2 prospective studies and that prospective RCTs are lacking. Uncertainty regarding oncologic outcomes has also limited Dex prescribing. In the present meta-analysis, it found no difference between Dex and the control group regarding the cancer response rate and survival, suggesting no influence of Dex and anthracycline anti-cancer activity in the breast cancer population study. So pharmacological prevention of cardiotoxicity, it's not widely used. ACEs, ARBs, beta blockers, they've been tested and as an option for primary prevention and have better data every year, and it looks very promising, but the level of existing evidence is not sufficiently strong to indicate these treatments routinely can significantly help all-comer breast cancer patients treated with anthracycline and or trastuzumab if needed. So in conclusion, dexrazoxane reduced the risk of clinical heart failure and cardiac events in breast cancer patients without undergoing anthracycline chemotherapy with or without trastuzumab, and it did not significantly impact cancer outcomes. However, due to the low quality of actual evidence available, further RCTs are warranted before systematic implementation of this therapy is utilized for primary cardioprotection. So no study is without limitations. So no RCT was judged as low risk of bias in all bias domains. The study relied on reporting of cardiotoxicity and or cardiac events. And there may be some patients with subclinical cardiotoxicity that were not included. And the definitions of cardiotoxicity and cardiac events also varied. They widely varied between the studies included, and none reported cardiac biomarkers to detect cardiotoxicity. And they did not assess the impact of the use of Dex in combination with anthracycline on hematologic toxicities. The clinical significance of this excess of hematologic toxicity, it could impact anti-tumor efficacy, but it was believed that this is unlikely because there was no adverse effects on these parameters in this review. So that was the study in and of itself. we could segue into some of the questions that would be most suited likely for our oncology colleagues, and some of them could be: what factors influence your decision to utilize dexrazoxane in your breast cancer patients? What factors contribute to you wanting to avoid its utilization in the same patients? In what patient would you seek a cardio-oncology opinion regarding the recommendation for use of dexrazoxane in your patients? Questions?
So, Chris, before you move on, thanks for a great presentation. This is Dan, by the way.
Hey, Dan.
So I think the questions that you have there are very good, but there are at least one or two other questions that I think are probably more impactful, and that would be, if instead of limiting this conversation to just breast cancer, there are many patients with lymphoma or sarcoma that are going to get much higher doses of anthracycline, or they've been previously treated with anthracycline and they have a recurrent lymphoma, for example, where those patients very likely would benefit dramatically from dexrazoxane, but it's really not given. I haven't, you know, we do see it used here at WashU, partly because of one provider, but the previous experience at other institutions would be that most oncologists are not really willing to use it. So I think the data that you presented was in breast cancer, which is certainly appropriate, but it's actually a bigger issue in other cancers that are typically treated with anthracyclines.
Yeah, you know, it's Joe. I have the same issue that in the leukemia oncologists, I get pushback all the time because they clearly falsely believe that it decreases the efficacy, and it's always a fight.
Yeah, these are great points. I appreciate both of you bringing them up, and all the experience that you've had at your institutions. Has there been instances where you felt that your opinion has been a little more heard relative to other instances when you're pushing for this cardioprotective strategy in certain patients? Or is there a patient population that they're treating that you can convince them that they're at higher risk, that would tip the scale for them using dexrazoxane?
Yeah, I think in the case of sarcoma, and especially here at WashU, we have several providers that have been very proactive, and so they're very, they're willing to consider dexrazoxane in an appropriate patient. And sarcoma is a much more, it's a rarer cancer than breast cancer, obviously, but it is typically sort of first line therapy is anthracycline until it doesn't work anymore. So they're going to get a lot of anthracycline, and upfront dexrazoxane could be critically important in their treatment. And Ron Krohn is on the call too, and he organized a study looking at using dexrazoxane in sarcoma patients proactively. So I think that this is a critical question. But the bigger place where I think, the conversations that I've had with breast cancer oncologists is, if they are contemplating anthracycline use and you say, well, this patient's at high risk, I would like for you to use dexrazoxane, they'll just turn around and say, oh, we'll use something else. So they'll pick some other drug that they have and not use anthracycline. Now, that may be an American pattern of behavior. There could be other patterns of behavior across the world where maybe they don't have all of the monoclonal antibody therapies readily available. And in that situation, anthracyclines may be a much much more important therapy, you know, in the international space. And actually, Chris, the first author of this paper that you're doing is on the call. I don't know if she can unmute herself and have any comments.
Hi, Dan. How are you?
I'm very good. Thanks for getting on, Ariane.
Thank you. Congratulations, Chris, for your presentation. It was great.
Thank you for being here.
Yes, then I feel that when we decide to perform this meta-analysis, the main issue in my mind was we need a more specific evidence to treat our breast cancer patients, because when we reviewed the Cochrane meta-analysis, as Chris has mentioned, it was a mix of various types of cancer, sarcoma, and children's cancer. So when we were discussing about giving dexrazoxane for our patients, always the oncologists or the hematologists, they were say, oh, there is no specific evidence for this type of cancer and so on. So when we decided to perform this, it was with this in our mind that we need to have a more specific evidence to treat our breast cancer patients. So, but of course, there is a room for sarcoma patients. There is a potential use for lymphoma patients. So in my mind, we need to extend this benefit for other type of patients. And I feel that for breast cancer, the evidence is good, but of course, we need more specific RCTs with this dose of anthracycline, also with trastuzumab incorporated, because our evidence now is from 2 small retrospective studies. So thank you for choosing the article to discuss. And I'm here if I can add anything more to the discussion.
Yeah, thank you so much for being a part of it. These are all great points. And so to move on to some questions specifically for the cardio-oncologist, in this instance, talking about our breast cancer patients. So what patients would you feel the most comfortable strongly recommending dexrazoxane cardioprotective therapy to, as it stands right now with the evidence that we have available currently? Is there a high enough risk patient without existing cardiomyopathy who plans to receive dual therapy with anthracycline and trastuzumab that you would push for dexrazoxane despite not breaking the current dose threshold for recommendation as far as the FDA is concerned? And then would you recommend dexrazoxane cardioprotective utilization in patients receiving index anthracyclines with or without trastuzumab if they develop asymptomatic reduction of ejection fraction, maybe a reduction in their global longitudinal strain, or elevated cardiac biomarkers that are subclinical evidence of cardiac dysfunction?
Yeah, Chris, these are all good questions. Again, I would go back to when you're having a conversation with a breast oncologist about their choice of therapies, and somewhere along the way they were contemplating anthracycline, and you bring up the idea of dexrazoxane, they will immediately switch away from anthracyclines. And I don't know all the reasons for that, but that's at least what happens in my observation in the United States. Now, the problem is that I can't really comment whether that strategy is the best strategy from a cancer outcome point of view. All I can say is that there are certainly high risk patients that are about to be treated with anthracycline where I would very much, counsel the use, for the use of dexrazoxane. So last week on our inpatient consult service, we had 2 patients that fit this bill perfectly. So one was a leukemia patient who was about to get induction chemotherapy, including an anthracycline, and he had mild LV dysfunction. His EF was in the 45 to 50% range. And then a second patient was a lymphoma patient that had a rapidly progressive lymphoma where a mass had grown on his hip and the side over a span of 2 weeks, and it was now the size of, you know, a pumpkin or something. So it was huge. And this had come on all in 2 weeks. And he had a previous stent procedure, had some evidence of a small area of infarct on his anterior septum, and his EF was right about 50. So by the general entry criteria for a clinical trial for the treatment of lymphoma, he qualified. But in that patient, I said, no, he's already had an infarct before. He's got evidence of diastolic heart failure. His NT-proBNP was over 2,000. You know, that would be a very high-risk patient, and they most certainly wanted to use anthracycline because it was a rapidly growing lymphoma. In that patient, I would say, absolutely, you should recommend Dexrazoxane because anthracyclines are so important in that treatment.
And I would say also, in addition to you know, the basic guideline-directed medical therapy, specifically for question number 3, for example, I would make sure that if the patient is able to tolerate standard, you know, heart failure beta blocker, ACE inhibitor, ARB, or ARNI, I mean, to actually have patients be on those medications in addition to the Dex. Just thinking about not only the short-term outcomes, but also the long-term outcomes for the patient.
Yeah, I mean, I think, Jose, your comments are, of course, on the money. If somebody has evidence of heart failure or they have a high risk for the development of heart failure, you should use standard heart failure medicines regardless. So the cardio-oncologist, that would be their go-to recommendation. But in patients that anthracyclines are being contemplated, Dexrazoxane is only useful in that with that therapy. So whereas the typical cardioprotective medications are appropriate for any patient getting any chemo, Dexrazoxane is really only useful in those in which anthracyclines are going to be used.
This is Joe. I have one comment and then 2 questions. So the first comment is there's sometimes some pushback because of the cost. That a single dose of Dex can cost up to $15,000. So there's sometimes pushback about.
I mean, what is that, Joe? Is that like designer Dex? I mean, it was approved in 1999.
I'm telling you, that's what it costs. It's look how much an EpiPen costs. So like, no, you can't make that statement. I mean, I would never make the decision about treating somebody because of the money, but I know that there's some pushback sometimes at the administrative level and at the pharmacy level because of the cost. So that's one thing. I want to extend this just a little bit to two other scenario about its use. So the first is, and we have done this, to use Dex with continuous infusion doxorubicin. So I would like to hear if anybody has done that. We have done it, and we basically do sort of a continuous, you just give it each day before the continuous infusion. So I don't know if anybody has done that. And then the other question that comes up when you sometimes say, I want to use Dex, they say, well, what if we want to switch and use pegylated liposomal doxil, and the use of that instead of Dex, and also the use of, does anybody use Dex along with doxil, which I've done a couple of times also. So I would open it up.
Yeah, I don't know how many times we've had that conversation. I would say it's less than 5 for for the two extraordinary items that you brought up. So I don't know how often you have that conversation.
Yeah, I mean, I think, you know, sometimes it depends on the specialty, and I agree with you about the sarcoma guys are like, they use it routinely when they start. So that, I mean, that's never an issue. They don't even ask us, they just do it, and everybody. I think the Doxil thing is more often a gyn-onc discussion than with other sub-oncology specialties.
I'd like to make a comment. I don't know, can you hear me?
Yeah.
Oh, good. There was some interesting basic data. You know, one of the mechanisms of dexrazoxane is it affects the topoisomerase 2 alpha, where beta is in the heart, and so it's thought that it decreases the topoisomerase 2 beta more than which is in the heart, so that when the doxorubicin acts, it doesn't act on the topoisomerase 2 in the heart, but it only acts on it in the tumor. And there were it was a small study, but they looked at a number of tumors, and the effect of the dexrazoxane in the tumors on their topoisomerase 2 alpha was different. And in some of the tumors, it did drop the topoisomerase 2 alpha, which would mean that when you gave the doxorubicin, it would not act on the tumor. And in some of the others, it didn't. And so it sort of raises the question that each tumor may be specific. And it has not been tested. I mean, we're testing it in sarcomas, and it seems to be protective without ruining efficacy. But it may be that in these other tumors, it has a more specific effect because of this relative topoisomerase 2 action. And so I think we have to be a little eyes open on this to just be sure that the efficacy is there. The studies in breast cancer, which was really a spectacular presentation today, it's that one trial by Swain a number of years ago, and she's even been quoted saying she wished she never did it. But it may be an issue with breast cancer, and as everybody said, our breast cancer doctors just don't give more than 300 milligrams per meter squared because they just stop and they've got all these other options. But in the options we're talking about, you know, doxorubicin is the best treatment that's available at the present time. So I just want to raise that point.
Yeah, I think that it's very hard to know what's happening at the tissue level in different specific cancers. So although that may, you know, it's certainly a concept, just imagine how difficult that would be able to prove in humans that are actively undergoing treatment. You'd have to have some biopsy or some sort of interrogation of the tumor itself while they're undergoing chemotherapy. So that's hard to produce in a human. I think animal models suggesting that may be interesting, but I think the difference between doing that in a human versus doing that in a mouse model is pretty large.
I don't think that you can actually use that except to be aware that I mean, just watch closely for efficacy effects. I mean, in this patient with the sarcoma or lymphoma that's growing like crazy, you're going to see a result, you know, so you'll know if it's working or not. And I think that's just very important to do. And usually the doxorubicin is not necessarily always the first choice. There may be better choices. Anyway, I think it's just worth thinking about.
So
Chris, it
Chris,
looks like there may be a couple other questions. I see hands on the screen. I think Isra, did you want to ask a question?
Hi, I was just asking about patients in the study. Among the patients using Dexrazoxane, where they are using cardioprotective ACE inhibitor or beta blocker, although they talk about this before a few minutes also.
Yeah, so Ariana, I don't know if you want to take that one.
Yes, I can answer this question. No, they were not under ACE inhibitors or beta blockers. If you realize the main decade when these studies were collected, it was early 90s, and the two other studies from from this century, these patients were not under any other type of cardiologic treatment, so they were not under ACE inhibitors or beta blockers.
Thank you so much.
So Chris, I don't know if you want to ask your questions that you had prepared or answer them rather. Yeah, Chris, I think you're muted.
There we go. I was muted by you. I must not have been saying anything worthwhile.
No, I was trying to unmute you.
Yeah, so question one, I'm sure everyone was able to read it already, but what's the proposed cardioprotective mechanism of Dexrazoxane? It was both the answer choices A and B. And an excellent point was brought up about the difference between topoisomerase 2A and 2B, one being specific for cardiac myocytes, the other being more active in metabolic tumor. So questions kind of unanswered moving forward that we'll keep in the forefront of our mind with further studies. Question two, what was the original patient population receiving anthracycline chemo that led to its hesitancy in prescription? And this was in our childhood cancer survivors who were initially diagnosed with leukemia or lymphoma. And most of the hesitancy, at least at the beginning, came from incidents of secondary malignancy, not so much reduced efficacy of the medication that we feel about with our breast cancer patient population.
Yeah, so Chris, before you go past that question, there is always a chance of secondary leukemia after patients receive anthracycline-based treatment, or they really receive any cytotoxic therapy. So that's going to happen at a certain rate whenever they're treated with anthracycline. And so originally there was some suspicion that Dexrazoxane would add to that, and that's where the answer C is correct. It was felt that perhaps childhood cancer survivors had a little higher incidence of secondary leukemia, but several studies have been performed in children in the recent years that have shown no increase and, you know, perhaps less of an incidence of secondary leukemia. But nonetheless, adults who got anthracycline are at risk for secondary leukemia to a certain degree. So
excellent points, Dan, per usual. And then our third and final question, it's a little wordy, so I apologize for that, but based on the available meta-analysis data from breast cancer patients treated with anthracycline with or without trastuzumab, which patient would potentially benefit the most from Dexrazoxane as a cardioprotective strategy in addition to current guideline-directed medical therapy? And it would be a survival of childhood cancer, maybe even one of our sarcoma patients who received anthracycline prior and has a new primary of non-metastatic breast cancer, who with a plan to receive additional anthracycline. So as it stands now, that would be an ideal patient to receive Dexrazoxane as cardioprotection in addition to everything else. And that is the presentation. I don't know if anyone has any final thoughts, words of wisdom, points of emphasis to make.
Now, Chris, this was an outstanding presentation. We appreciate it. And your picture of Louisville is certainly peaceful. Is that the way it really is?
It wasn't that way at the very beginning. I mean, as you know, this is where the unfortunately Breonna Taylor incident happened in February. Everyone was very active at the beginning of the protests here downtown. All of our distilleries were busted open, which is unfortunate. I'm a big bourbon guy. I know there's a lot of fires and what have you. So very similar to kind of around the country, but things have quieted down quite a bit, and we're able to, I think, put our best foot forward, much like everywhere else, and continue things peacefully. But things are okay. I appreciate you asking.
Yeah, no, it's.
If I could go ahead. If I could comment, I think, Chris, that was a fantastic review. I just wonder if you could put a bibliography and just mail it, put it out there for the ICOS so we could just get the some of those that Cochrane. I mean, I've got them, but it really was an outstanding review of the literature and synthesis.
Well, thank you very much. Yeah, I'm more than happy to send a bibliography to Steve, and he can make sure it's available to everybody.
Yeah, happy to do that. It looks like Carrie Sturka, did you have a question? I see a hand. And maybe Dan in Israel, Dan Gilom, did you have a comment or question?
I was just going to comment, that's all, Steve, but that's good. Thank you.
Dan, also from Israel, just a great talk, and thank you very much. I've learned a lot.
Yeah, appreciate it. Thank you very much. It was a great presentation.
Thank you for choosing the article. I feel that we need to bring this discussion about cardioprotection to the table. And I really appreciate the presentation. Thank you, Chris. It was great.
No, I agree, Ariana. I think the need to revisit the whole dogma about Dexrazoxane is super important, especially, maybe not so much in the breast cancer population, although that's certainly possible. There's a possible need there, but really in the other cancers where, for the most part, all the other oncologists have taken the lead from the breast oncologists to not use this therapy. And what evidence is there, and what we show, what we showed from Ariana's article is that Dexrazoxane does look cardioprotective, and there's no real safety signals. So I think that we need to rethink our use.
So I'll make one final comment that the whole argument is kind of ridiculous, because if you look at the ASCO guidelines and the package insert, it says that if anthracyclines are effective and you reach 300 milligrams per meter squared in breast cancer, that it's okay to use it for cardioprotection. So that if there was some thought that it reduces the efficacy, why would they make that conclusion and say that's okay to use there in metastatic breast cancer? So I think the whole argument is spurious, that there's a decrease in efficacy of cancer treatment. And honestly, Sandra Swain did us a very big disservice. That's all.
All right, well, thank you everybody for attending. And Steve, I know we have something next week. Do you know what we got going next week?
I know it's a case review. I don't have the topic off the top of my head, but we'll send out an email reminder for sure.
Yeah, it's an interesting case of heart failure. So.
Oh, that's right, Joe. It's coming from you.
Yeah.
Give us a commercial.
Perfect. Everybody needs to get on and throw their tomatoes at Joe.
Yeah, and with the summer growing season, you should have a lot of tomatoes.
That's right. All right, very good. Thank you all.
Bye, guys.
Thanks, everybody.
you.
Thanks, Chris.
Thanks
Stay
everybody
well.
for your
Thanks, Chris.
participation.
Great.
Thank you.
Thank you. Thank you, everybody.
Thank you. Thank you very much. Thank you for nice presentation.